Forum number 1. It is so nice to see all of you here this morning. We have a packed agenda as we're going to be focusing on essential partners in emergency planning and response. If folks can mute themselves, that would be greatly appreciated. We're getting some background noises. Great, thank you. Carol, you can go to the next slide. I'm Ariana Stone, HCA's Director of Research and Development. I will be co-hosting today's forum with Carol Dioy, HCP's Director of Regulatory Affairs and Special Programs, and Ava Cohen's, HPCANYS Director of Regulatory and Community Affairs. Next slide. A few housekeeping items before we dive into today's agenda. We kindly ask folks to remain muted throughout the presentations. Today's forum is being recorded and the recording will be made available as well as the presentation slides. And lastly, these forums are meant to be interactive, so feel free to ask any questions, share your comments, and please utilize the chat. All 3 associations will be monitoring the chat throughout today's forum. Next slide. So this project was supported by the Department of Health and Human Services Administration for Strategic Preparedness and Response under a grant that all 3 associations received. Its content is solely the responsibility of the authors and does not necessarily represent the official views of the Department of Health and Human Services Administration for Strategic Preparedness and Response. All 3 associations would like to thank the New York City Department of Health and Mental Hygiene and the entire team, Fidel, Darren, and Matt. We really appreciate your ongoing support. I'm going to pause here and let Fidel Monroe say a few opening remarks.
Thank you, Ariana. Good morning, everyone. I'm Fidel Monroe, as Ariana just stated. Some of you may have heard me speak before or may have met me at some point. I am the Home Care and Hospice Liaison for Long-Term Care Emergency Preparedness at the New York City Department of Health and Mental Hygiene, Office of Emergency Preparedness and Response, and the Bureau of Healthcare and Community Readiness. My bureau has a specific mission, and that is to support the New York City healthcare system to respond safely and effectively in emergencies. To do this, we align much of our work with the healthcare preparedness capabilities driven by the Department of Health and Human Services Administration for Strategic Preparedness and Response, which is referred to as ASPA, as Ariana just stated. Offerings such as today's forum are made possible by the funding dollars provided by ASPA's Hospital Preparedness Program, referred to as HPP, which allows us to focus our efforts on building and maintaining a prepared healthcare system, advancing the development of the New York City Healthcare Coalition, strengthening regional coordination, and ensuring the healthcare system can maintain operations and surge to provide acute medical care during all health hazards emergencies. So how are these funding dollars used to benefit the home care and hospice and palliative care sectors? With the support of the associations here, Home Care Associations, Palliative Care, the Palliative Care Association, we offer sector-based activities with the goal of providing fundamental education aimed at strengthening the internal capacities and capabilities of the sectors in increasing their ability to partner with public health to improve mitigation, preparedness, response, and recovery in disasters. Important in what I just said there was the partnering. I mentioned funding dollars and funding source because of note, all the programs offered through the New York City Health Department are free of charge to every agency in New York City that participates. So I encourage you to use opportunities such as this to advance your agency's healthcare readiness to meet future hazards in a changing world. This forum will highlight the value of developing and maintaining partnerships within the communities in which you live, work, and/or provide services. I'll also add the renewal of existing provider relationships and coordination with other healthcare sectors, which along with home care and hospice and palliative care, comprise the New York City Healthcare Coalition. You may have previously heard me say that if you're ever asked who makes up the New York City Healthcare Coalition, it's all of us. The New York City Healthcare Coalition is a collaboration of health and non-health partners organized in support of the healthcare system preparedness and response to an emergency, mass casualty, or catastrophic event in New York City. The coalition brings together various partners and sectors into a single integrated and coordinated healthcare system, emergency planning and response entity, leveraging the strength of each member, whether that be home care, hospice and palliative care, the hospital sectors. We leverage the strengths of each partner during an emergency. Today's featured presentation is being delivered by one of our coalition partners, the Staten Island community organization active in disasters. I would like to thank them for being here today. I also thank you for participating in today's forum, and I acknowledge that the healthcare system in New York City, strengthened with the addition of home care and hospice and palliative care sectors to the New York City Healthcare Coalition, which continues to grow stronger because of your involvement and feedback. But more than that, we would not be able to do what we do if it were not for your agency's collaboration with us on these important emergency preparedness initiatives. It is our continued hope that your participation in our offerings allows you to take from the experiences of others and incorporate lessons learned into your own emergency planning. I would like to wish each of you a wonderful holiday season and a happy new year. Thank you.
Thank you
Back
so
to you,
much,
Ariana.
Fidel.
You're welcome. Thank you.
Today's forum will focus on how home care and hospice providers are essential partners in emergency planning and response. To illustrate the value of partnership and collaboration, the Staten Island Community Organizations Active in Disasters, also known as the COAD, will provide an overview of their enhanced experience partnering with the home and community-based services during the COVID-19 pandemic. The Staten Island COAD will also discuss key outcomes, best practices, and lessons learned. Today's forum will conclude with the associations providing updates on current emergency-related issues, leading right into an open discussion. Next slide, and over to you, Carol.
Thanks, Ariana, and thank you, Fidel, for providing such a great overview and really stressing the collaboration that we're building here. And thank you to all the participants for being here. So we are the New York State Home Care and Hospice Associations. You may not know that New York State has the nation's most comprehensive and diverse system for home and community-based services. Out of all the states in the nation, we are the leaders. So HCP, HCA, NYS, and HPCANYS, we represent providers statewide in this large critical sector of the healthcare continuum. Our association staff at each of these three agencies, we are hard workers and we wear many, many hats. We are responsible for programs such as this. We provide technical assistance to providers. And I like to kind of sum up all of what we do as education, advocacy, and communication. And all of those things are not just for the providers, for the patients, but also in the realm of emergency management. We provide education such as this, advocacy to try to make things better, and communication, especially before, during, and after emergencies. So I'm just going to give you a overview of home care and hospice, and then I'm going to turn it over to Eva to talk specifically about hospice. There are a lot of different levels and types of care provided by our providers. We have CHAs, Certified Home Health Agencies, licensed home care services agencies, we call them LHCAs, are responsible for a lot of personal care to allow people to stay in their homes. And then, of course, we have the hospice and palliative care providers. There are other types of providers that we don't often think of. We have fiscal intermediaries in the consumer-directed program. There are long-term home healthcare programs. Managed long-term care plans are also one of the partners that helps get services to the patients. And the home and community-based waiver programs are the nursing home transition and diversion program and the traumatic brain injury, TBI, NHTD and TBI programs, which serve a little niche of our society, keeping folks out of institutional care. So specifically focused on home care now, our clients are from the entire spectrum of care, from children to adults to senior citizens. Some folks have public health needs, such as immunizations. Professional services are provided, personal care services, as I mentioned, housekeeping. Folks need errands run. We take care of new moms, infants, folks on ventilators. So home care clients really run the gamut of every kind of healthcare you can imagine, but provided in the home and the community so that it keeps folks connected to their families, to their neighborhoods, to local businesses. So home care really not only helps the patient, it helps the community, helps the economy in the long run. We are really an essential part of the team. Now I'm going to turn it over to Eva, who's going to talk about hospice and palliative care specifically.
Thank you, Carol. So hospice is, I wanted to say really quickly that hospice is a philosophy of care. It may or may not be a place. Hospice care focuses on improving the quality of life for persons and their families faced with life-limiting illness, generally 6 months or less. And the primary goal of hospice is comfort, relief of physical, emotional, and spiritual suffering, and to promote the dignity of terminally ill people. Hospice care neither prolongs or hastens deaths. And sometimes people get a little confused about the difference between hospice and palliative care. Palliative care is also symptom relief, but a lot of patients who are receiving palliative care are also receiving aggressive or active treatment for their disease process, such as chemotherapy, dialysis, or radiation. Palliative care patients reside at home, and most need support during their illness. Most get well and live long lives. Patients are often very high-tech, dependent on medication delivery and a power source, and may or may not be served by a home care or a hospice agency. A little bit more about hospice and palliative care programs is that they also serve patients of all ages, and they can look differently. Hospices can look differently, but are required to provide the same set of services. Some are part of a continuum of care provided by a large health system, but most are independently operated. A few still remain part of a county health department. There are approximately 39 hospice providers in New York State, 8 serving the boroughs of New York City, and 3 serving the residents of Long Island. Although most counties have only 1 certified or licensed provider, crossover exists, especially in New York City and Long Island. Palliative care programs are not as structured. They are currently provided by hospice programs, CHA programs, and hospital systems. New at the Department of Health is the Center for Hospice and Palliative Care, and that is now established and staffed. Emergency preparedness requirements vary based on hospice location and level of care, and it is important to know where each of the units and facilities are in your specific community. Next slide. Emergency planning efforts of all the associations have the common mutual goal. It's to support collaborative emergency planning and response and to ensure the health and safety of medically needy individuals receiving care at home or in a facility that we serve. And we do that by providing education, the communications that each association sends out, and by encouraging collaboration and legislative advocacy. Next slide, please. Home and community-based services, and there's so many acronyms, but often referred to as HCBS, Emergency Preparedness Laws, Rules, and Regulations. We all have them. All agency has those. Agency requirements vary by type of provider. They are specified in the Department of Health Administrative Guidelines. Commonalities include risk assessment and planning, policies and procedures, communication plan, training and testing, and those are requirements for all providers. Specifically, those look like a 24-hour, 7-day-a-week emergency contact and staff call-down list, a current list of community contacts and partners, including the local health department. Law enforcement and others are also partners in emergency planning. Participation in drills and exercises is required, so please invite us. Participation in the health commerce system and keeping your roles updated is also required. And a list of patients, a roster with emergency contacts is required by all, and prioritization of patients by level, TALs, 1, 2, and 3, transportation assistant levels, is also required. I think it's over to you, Carol. Nope, I have one more. We've already talked about the state association's role in emergency preparedness and response. And you know that we're about education and communication and advocacy, but we've also have that in that we also have an expanded role of teaching our partners in the community about our roles, what we do as home care and hospice providers. And we have taken that role on very specifically with Hospice and Palliative Care Association and HCP and HCA. So let us know if there's anything else that we need to do to help you maintain your emergency preparedness and response, regulations, and or anything you need education on. Over to Carol.
Carol, you're muted.
Thanks. I tried to echo what Eva said. I apparently was not echoing. Reach out to us if there's anything you ever need, or if you're having an exercise and you need observers. We're always happy to lend a hand with your emergency management activities. So in home and community-based services, we have unique challenges as compared to our hospital partners and clinic partners. Our geographic areas are often huge. A home care agency may cover 3 boroughs. So any emergency that happens in one isn't necessarily happening in another. It's not just one location, like a hospital would have one facility where they have to lock things down. Our patients are spread across a very wide geography. And the other thing is that every patient home can be an emergency in and of itself. There could be one apartment building that's having a problem, a bomb scare or flooding. There could be just one neighborhood, but any one house can be its own emergency. Sometimes communications are difficult in home and community-based care. We don't often have radio access, like a hospital might have a whole radio system when the internet is down. That can be very difficult for home care providers to work around and try to get a hold of their patients, get a hold of their workers. Patient access is particularly affected. It can, if you think about an emergency in a hospital, you have to use the stairs instead of the elevator to get to somebody. But when you're talking about home care and there's a snowstorm, you need a snowmobile and snowshoes. You don't have a staircase to get to each patient's home. So access is definitely something that we focus on very much. And we want to remind folks that home care and hospice providers can assist across different settings during an emergency. While we are usually short-staffed, sometimes we can spare people to help alleviate staffing shortages in other situations. We may have some staff that are particularly good at dealing with emergencies that are willing to help out. Oftentimes when we're participating with hospitals in some of these activities, there's talk about decompression from nursing homes and from hospitals to send people home to free up space in the facility. And we want those folks to know that we can partner with them, and we need to keep those communication channels open so that folks can go home. Some more unique challenges. There are often patient or family fears when there's an emergency. They don't want to let folks in the house. We saw that a lot with COVID. People were so hunkered down, they didn't want to let a home care aide in to assist them with their activities of daily living. So there are fears. We have unstructured environments. When a home care worker goes into a residence, they don't know what equipment is available. They don't know if there's a fire extinguisher. They don't know if there's a snow shovel. It's a lot of little things that the home care provider and hospice providers don't have control over. So every environment is a different environment. We had problems with inadequacy and unaffordability of PPE during the COVID pandemic. The associations helped our providers get access to PPE because folks needed to be protected when they went into patient homes. Transportation, I want to talk about this for a second. We have access issues and transportation issues for workers and patients during an emergency. The associations are really focusing on trying to get legislation passed this year to make sure that it's in law that home care workers, home and community-based services workers of all kinds are considered essential employees for travel. There was a story in Buffalo. Eva, I know, had a great experience with this, with hospice workers trying to get to people's homes during a huge snowstorm, and they weren't allowed passage. So we need a widespread recognition of these workers as essential. And then the transportation piece, HCP has been working with DOHMH. Fidel has been instrumental in helping me with this program to come up with an agreement between transportation providers and home care providers for the transportation folks to help out in an emergency with moving patients and possibly moving workers. So watch for more on that. We're hoping to have a template for folks to use coming out this spring. So we are an essential part of the team, and yet we still have struggles, especially with emergency management. As I mentioned, access to patient homes. We don't have, priority access to fuel. We have some regulatory issues that we are trying to overcome as far as paperwork goes, as far as funding goes. There is no funding that goes to home care providers for their emergency management efforts. Everything they do is just to live up to the regulations and go over and above the regulations to help their patients with no funding to pay for that. As I mentioned, radio communications are off limits to us in a lot of cases. That equipment is expensive. And again, there's no funding for that. So that's something that we advocate for regularly for our providers. And transportation, I did talk about. And I think we are we back to you, Eva?
Thanks, Carol. This is my absolute favorite part of this presentation that Carol and Ariana have done in the past. But community-based providers offer a unique package of strengths in emergency preparedness. And sometimes we're forgotten about, but we employ highly skilled clinicians and non-clinical workers that are geographically local. They know the communities they serve. They're resourceful, they're independent thinkers because they're on their own in the community most of the time. They're flexible. Their schedules change minute by minute. They are skilled problem solvers when it comes to getting equipment, supplies they need, or just solving problems that come up day to day. And they are adept at handling emergencies. Home and community-based workers are team players, just by nature. Next slide. I think there we go. And so there are opportunities for you as hospital systems, as nursing homes, as emergency preparedness people, as Department of Health or OEMs. There are opportunities for collaboration, and there are opportunities for us to expand our own collaboration so that we're working with hospitals and physicians, and to communicate, improve communication, community partners, and improve our education to patients. Those are opportunities that we all share. And there are opportunities for shared business innovations, things that work that we can share with one another that have worked in emergencies in the past and will work moving forward. And we need to update, and it's an opportunity that we're always looking to update infectious control and care management techniques. and new ways of doing business. And sometimes that involves IT. One example of that would be staff safety devices that some agencies employ, both in home care and in hospice. And we always have the opportunity together to communicate with policymakers and to advocate with legislators just to improve our regulatory guidance. And we have further opportunity to educate the community and healthcare partners. So I thank you for joining today. I think it's over to Ariana. Oh, I have one more. My favorite slide. Carol always puts it in. I'm so happy about that. It's Mr. Rogers. Most of us know Mr. Rogers, but who are the people in your neighborhood? And how can we help one another during a disaster or an emergency? Home care workers know other home care workers in their neighborhood that they serve. The nurse might know the therapist. They all know who the aides are. They see each other in their communities, but do they see you?
Before we go on to our next presentation, there is a question in the chat. How do you address some of your vulnerabilities? For example, communication limitations.
Is that for me, Ariana? It used to be in the old days, we used pagers to communicate with one another. So we've come a long way, right? We don't do that anymore. We have cell phones and we use those. Home care workers, aides, a lot of times we do scheduling. They have emergency alerts on their phones. So we use cells for the most part as our main means of communication. But we don't, a lot of the nursing homes have ham radios, those sort of things. We don't have that. So we're really, if cell goes down, that's something we should probably practice and drill for, because we would really have a difficult time with that, as they have where the hurricane was in the Carolinas when their cells went down. So they have great stories about that maybe we should hear sometime. But we mainly communicate by cell phone.
And I just want to add to that, we often urge folks to use a mass notification system for providers so that you don't have to call every single person. There are a lot of different systems out there that you can send a blanket text only to the aides or only to the nurses or only to the supervisors to get messaging out very quickly to a lot of people. And it can go via text or via email. Unfortunately, you know, this world, like Eva said, we are so reliant on technology. But radios is definitely something to look into. Funding for that, Fidel, would be great. As if Fidel writes the checks.
And also those mass communication systems are not cheap either. An example of that would be Send Word Now. That's a good one, or the one that I've used in the past with an agency I was with before. They work great, those mass communications, but they're only as good as your call down list. If your information is not current for your staff or your patients or their emergency contact, then mass communication is not going to work. So you have to keep those lists current.
And I'll put a plug in there. We'll have a link at the end for the videos, the recording of this. We have a presentation on mass notification systems that was recorded last year, if anyone's interested in that. And Fidel, you wanted to say something about writing checks.
Oh, no, Carol, I'll pass on that, but there is opportunity for equipment for the associations, but you know, it's something that we can discuss for further projects.
And you know, I was just teasing you. I wasn't.
I know that.
Okay. Yeah.
Do we have time for one more question? It looks like Tina has her hand raised.
Sure.
Actually, it wasn't a question, just more of a statement. So in addition to SendWord now, there's also Everbridge, but they are very expensive. They're not very cheap to actually attain. With respect to the ham radios, we do have quite a few volunteers on Staten Island that have assisted us. In fact, Aries was the one who assisted Rumsey in terms of getting that program up and running. And they do have volunteers that would actually go to your actual site and provide that training. So that's something that you possibly could actually try to join efforts with and see how they will be able to support the communication portion.
Well, that's great. And another example of who's your neighbor and who can help you.
Exactly.
Great. So up next on the agenda is the Staten Island COAD. Today we are joined by Dr. Ginny Mantello, the Director of Health and Wellness for the Staten Island Borough President's Office and attending neuroradiologist at Montefiore Medical Center. Dr. Mantello has over 26 years of experience. We are also joined by Tina Campbell, Director of Environmental Health and Safety Emergency Preparedness at Richmond University Medical Center. Tina is a dedicated leader in enhancing Staten Island's health and safety with nearly 2 decades of experience. And lastly, Michelle Bascome, Director of Programs and Development at the nonprofit Staten Island. Michelle leads the Staten Island community organization Active in Disaster and brings over a decade of experience. Please join me in welcoming Dr. Mantello, Tina, and Michelle.
Thanks so much, team. Good morning. My name is Michelle Bascome. I'm going to be kicking us off, and my co-facilitators will be happy to introduce themselves shortly. But thank you so much for the invitation, for having us. It's wonderful to meet the network and learn a little bit more about other association and coalition work that's happening around our city. As mentioned, my name is Michelle Bascome. I'm the Director of Programs and Development at nonprofit Staten Island, and in that capacity, I serve as the Managing Director of our Staten Island COAD Coalition, which we're going to get into, and we're excited to speak with you all this morning about cross-sector emergency preparedness, specifically by sharing out some of the successes and challenges of our own coalition's integration of a medical ecosystem subcommittee and the work that's happening with cross-sector collaboration in our borough in the realm of emergency preparedness. For context, if you're unfamiliar with COADs or the COAD model, the Staten Island COAD stands for Community Organizations Active in Disaster. As mentioned, we're anchored in a larger membership association, nonprofit Staten Island. But the mission of this coalition is really to build capacity and resilience in a way that better prepares our local organizations for future large-scale emergencies or everyday disasters. And our work and our mission is very similar to what I'm hearing from the association. It's around communication, advocacy, and education. Specifically, we zero in tremendously on situational awareness and assessing needs and gaps so that we're taking really strategic approaches to enhance the capacity and supports available to the members of our network. And I want to just give, my role here is to really offer the framing around the coalition and how our medical ecosystem has been embedded in that. Inclusivity in emergency preparedness, I think our hosts here did a wonderful job really introducing this concept. And to just put a brief and finer point on it as we get into our case examples here, we really want to share out our big lesson learned that inclusivity strengthens the effort, right? Cross-sector and collaborative response preparedness leads to collaborative response, which really helps to advance equity, trust building, and ultimately an efficient response here. So my slide is a little bit more animated than I like it to be, but on the equity point, we see that our cross-sector approach and the inclusivity of, specifically in this case, medical providers and health facilities to the CBO, FBO network initially really helps improve connectivity across the board to special needs and hard-to-reach populations, vulnerable populations, and also, for what it's worth, smaller organizations who really benefit from the centralized access to government agencies, official updates, resources that are being distributed. And building equity at that local level by working together is really critical. It also enhances the efficiency as the processes move along. And I don't want to jump to Tina's slide around mitigation and preparedness, but really important phases of mitigation and preparedness lead to a well-formed and strategic response, or as well as a response can be. Strengthened information and resource sharing across providers runs more efficiently when it's go time, if you will, if that preparedness work has been done collaboratively, if folks are at the table together, really thinking about what that looks like, who is contributing what, and who is connected to what information and what resources. The unified approach is really critical to advocacy as well, and the mobilization of resources, as you'll hear throughout our presentation here today. bringing everyone to the table positions us for greater advocacy for the local needs, right? And I think that, again, it was a really nice job highlighting that up front here, that is part of the benefit of an association. And it's wonderful to see so many of you all coming together to learn together. And that unification really can kind of continue and transcend the education space into an activation. And finally, trust, the hyper-local awareness, and this might even be back to the Mr. Rogers point. Hyper-local awareness and knowledge is something that each one of you carry and holds within your own professional self and your own institution. The ability to leverage that expertise, not only of your professional life, but of your community, does help to build trust across the sector and also across the community, again, when things can be in crisis mode really difficult to trust and to manage and to navigate. The stronger partnerships fostered through early work, through preparedness work, allows for more consistent collaboration and equitable inclusivity as a response becomes more necessary or as long-term recovery gets underway. So this is, again, just an offering to say that we're here in the spirit of talking about building cross-sector partnerships, of encouraging you all to really lean into the expertise and knowledge base that you have, and consider the ways that you can offer that to other partners and stakeholders and providers in your area, and perhaps in other boroughs, if and when the situation may call for it. Let me hand it over to my colleague, allow her to introduce herself and give us a little bit more anchoring for the larger picture here. Tina Campbell from Richmond University Medical Center.
Thank you, Michelle. Again, good morning, everyone. My name is Trientina Campbell. I am Director of Environmental Health and Safety here at Richmond University Medical Center, and I'm also the Emergency Preparedness Coordinator. Been working in that role for over 20 years. I have been involved in, this is my second coalition on Staten Island that I've actually been involved in. And basically, what I really wanted to demonstrate with this slide specifically has to do with really how we emerge from literally focusing on mitigation and preparedness to now going through the 4 phases of emergency management. Initially, when we look at it, all the folks that were around the table kept on repeating the same word. We could only do mitigation and preparedness. It is impossible for us to be able, as a coalition, to work and support our main organization and still support the rest of the coalition. And it's something that is renounced in pretty much every coalition I've been involved in. It has always been the focus of, let us just look at mitigation preparedness because we cannot lend ourselves to doing response and recovery. But with COVID hitting ground, that literally changed the entire dynamic of what we consider emergency response to be. As in the past, we are used to emergencies happening over a 24-hour, 48-hour, up to a 72-hour period. But COVID actually showed us a different way to what emergency preparedness is all about. And with that, we migrated from just doing our regular hazard vulnerability analysis and do our plannings. And to be honest with you, we did have quite a bit of people sit around the table doing that hazard vulnerability analysis, providing different ideas and concepts as to what the vulnerabilities of the Staten Island community is really all about, and which then emerge itself into creating plans to try to address some of those vulnerabilities that we have identified and some of those risks that we have heightened alert around. Specifically, one of them was snowstorm and tropical storm hurricanes. That was really what our focus was, to the point where we literally had National Guards involved. We had Con Edison. We had a whole variety of different individuals at the table providing their analysis and idea. The coalition, the Staten Island Coalition specifically, started in 2012 after Hurricane Sandy, and it wasn't started by the hospital, strangely. It was actually started through the Staten Island Not-for-Profit, which is now Not-for-Profit for Staten Island. They were the one who initially said, let's bring the group around the table and invite the hospitals to participate in that. So as I said, we have migrated from just being mitigation preparedness to being now involved in the response and recovery, but in a different way. It's not response and recovery as opposed to how you respond in your organization, where it's an everyday, day-to-day activity. It is more of looking at it from a broader spectrum and being able to address some of the response levels that needed to be addressed at the community level and not at the individual organization. With that, I will turn it over to Dr. Mantello, who will go through a little bit more details as to the makeup of the Medical Ecosystem Subcommittee. Thank you.
Thank you, Tina, and good morning, everyone. I want to start by thanking the Home Care and Hospice Associations for inviting us today to speak. Some of you might have heard about the COAD and our efforts, and we'll talk about our presentation about the importance of collaboration, but I also want to emphasize having the umbrella agencies at the table, having this ability to have constant communication. It's key. I sit in this role. It's rather unique because, yes, you heard correctly, I am a neuroradiologist and still practicing, but my passion is public health and community health. So I have been acting in the role of the health director out of the borough president's office for 11 years now, almost. And I'm kind of uniquely situated because I'm in healthcare as well as in a government office. And that really became pretty critical in the way we responded. And you'll hear us talk about trust over and over again. And I'll also talk a little bit about the Mr. Rogers approach. I mean, Staten Island's a small community. You can almost wrap your arms around it. And key partners constantly communicate whether it's a disaster or not. I mean, sadly, we all know, we call it emergency preparedness, and mitigation is so critical, yet we get so involved in other priorities, and really it's only when a disaster strikes that we kind of scramble and come together. But constantly staying in communication is key. So it was very interesting because Tina mentioned this is the second coalition she's been part of. The first time the coalition was set up on Staten Island was actually through the Medical Society of Staten Island, and that was post 9/11. And they also were funded through the health department and had the hospitals at the table and many other agencies, but then they didn't have the bandwidth or the funding to continue, and they stopped. And that's when the nonprofit, post-Sandy nonprofit associations came together. They also felt that they were being left out, and oftentimes they were not invited to the table. And they were important both in terms of response and recovery, as well as preparedness. So in parallel to what was going on with the COAD, and unbeknownst to the Medical Society and myself and my office, the Medical Society approached me to set up a medical response like they had previously had done. And so the medical ecosystem actually really started in parallel. And then because, like I said, many of the local leaders often talk in one such conversation with the leadership of the COAD, I happened to mention the emergency preparedness work that I was doing. And they were like, do you know about the COAD? And so, of course, it makes sense to bring the two together. And fortunately for me, the hospitals were already at the table with the COAD. There were also partnerships with the health department and NICEM. And so we worked together along with local healthcare leaders, the Medical Society, clinicians, city representatives, and really began to think about what that medical framework might look like, and how we could enhance and strengthen the COAD, by adding that medical ecosystem. So we began looking at different sectors: pharmacies, hospitals, nursing homes, adult homes, group homes, other sectors like dialysis, social care agencies, mental health agencies, and of course, hospice, home health, and federally qualified health centers. And so I believe it was a couple of years after, so in about 2015 or so, the medical ecosystem and COAD came in, and then but towards the end of 2015, early 2016, we kind of formalized that and made the medical ecosystem a subcommittee of the COAD. Of course, not at all expecting that a few years down the road, we would be in the thick of a medical disaster. Next slide. Okay, so as I mentioned, and Tina mentioned, that initially the COAD was more a preparedness and situational awareness agency, and that's what we had really been focusing on, strengthening our partners to be prepared and to be aware of what's going on. But when COVID hit, very quickly we realized we had to do much more than just situational awareness. And so we quickly pivoted to a response and recovery organization or coalition. And you'll hear throughout the presentation a lot of things that happened. Even as we were putting this together, it was, traumatic to just think about those very, very intense 18-hour long days. But our presentation will focus on some of, how we did the needs assessment, how we mobilized, how we advocated on a daily basis with the city, the state, and beyond, how we coordinated support for providers, as well as how we went from transition from testing to vaccination efforts. And throughout, we will sort of highlight some successes as well as challenges that we experienced. Next slide. So, the hospitals had their own incident command teams set up and established. But we knew that we needed a more community-focused effort. And so with the support of the borough president and in my role, we were able to really set up a community incident command system team. And that really consisted of representations from both local hospitals. We had the chief medical officers, we had the safety officers, we had our nursing home representative, we had medical and primary care physicians from the medical society, of course, our representation from our COAD and myself. And this group met daily to discuss challenges and response efforts and really advocate on behalf of Staten Island, both to city and state agencies. And, we say this and really not, we felt all along, or we feel all along, oftentimes Staten Island, being the smallest borough, gets left out, and we don't have our own health and hospital facility. We oftentimes get left out, and we really feel like we had to, felt like we had to advocate really hard on behalf of our agencies to both the city and state. And not only that, we also made sure that all of the mandates, resources, et cetera, and opportunities, that we had the opportunity to really simplify it for our community and all of our partners on a regular basis. And I think we all remember almost daily or weekly conflicting updated mandates, updated messaging, and it was a lot for everybody to handle. So we tried our best to sort of simplify it for the coalition and beyond. And you talked about, the Mr. Rogers approach, and we talk over and over about trust. And really, the work moves forward at the speed of trust. And I think that many of us that have been doing it so long in the community have really been boots on the ground and established that trust. And a lot of what we were able to do really was based on that trust, those trusted relationships with our CBOs, with our grassroots agencies, with our faith-based agencies, and so on and so forth. And, when COVID hit, we really didn't even know who was out there. We didn't know who needed to stay open, who were the essential workers, who were those that had residential facilities, who do we even start to reach out to? So we began to look for those Mr. Rogers in our neighborhoods and really think about, how do we, even beyond our COAD coalition, how do we help the community at large? So we really, and we also began partnering with our long-term recovery agencies, and they had been doing this for a lot longer. So they had recently done a needs assessment. So we adopted the needs assessment from the LTRO. And we began extensively surveying, not just in the medical ecosystem, but even restaurant workers, food delivery services, obviously group homes, residential homes, nursing homes, long-term care, who needed to keep their door open, how many staff did each of these agencies have, how many individuals did they service, how much in terms of resources did they need. So we really did a cross-sector evaluation for the first few months in partnership with the nonprofit Staten Island, as well as the Staten Island Borough President's Office. And then we began to fundraise really to be able to tailor and meet the specific needs of our community, be it, cleaning supplies, sanitation, sanitary, hand sanitizers, PPE, masks, gloves, gowns, and so on and so forth. So really tailoring to how many staff members, how many people they service, and how do we get them the resources. And we did multiple efforts. We took donations. The local elected officials all banded together. Any donations that were received in the community really went to almost one central repository. So we, because we had this needs assessment and we had a good sense of who needed what. And so we were able to parse out, PPE and resources based on the requirements and the needs of our community. We had many donations that came our way. We had, masks, like 185,000 masks that were shipped from another part of the country to us. We had, local nonprofits and others banding together to create tests, whether it be 3D tests or it was masks or goggles. So, there was lots and lots of efforts and lots of donations. And we were fundraising through nonprofit Staten Island to be able to meet the needs of our community and those essential partners that needed to stay open. So in addition to all of that, we also spent a lot of time on training and education. So not just training the community on the appropriate PPE, what kind of masks are critical, whether it was, I think back, we went from no masks, cloth masks, to surgical masks, to double masking, to KN95 to N95. So there was, people were really confused. So we tried to make it simple. Tried to explain the importance of everybody masking and how that stopped the spread. Of course, stopping the spread practices, but really looking at all the messaging that came from CDC. And we emphasized, of course, making sure that we really only focused on either messaging through our state or our city DOH or CDC. And so that people understood that there was a lot going on social media, but really to sort of stay with the trusted, whether it's the COAD or some of the city and state trusted partners. And really, we heard this often. The COAD happened to become the resource for a lot of training and education for many of the small CBOs and nonprofits and faith-based organizations, grassroots, that would have normally not known where to turn or didn't get messaging, say perhaps from the city health department or the state or other resources. So we were pushing out information on a daily basis. I mean, I can say personally, I must have done hundreds of webinars early on, whether it was one-on-one, small group, large group, town halls. Anytime somebody had a question, we were always had an open door approach. We were always available. People could communicate with the COAD or directly with us at the borough president's office or at the hospital if they had a question or if they didn't know where to turn. And so, the resources were made available to our agencies through all these efforts. We also wanted to make sure that we were participating in citywide response efforts. Thankfully, Tina, being in a hospital setting, was part of the group that NISM had put together on a regular basis. My office and I were talking to the mayor's office on a daily basis. We were talking to the city health department on a daily basis. The borough president was on daily, sometimes weekly calls with the rest of the elected officials as well as the mayor. So we kept on advocating for any resources that we needed beyond what we were able to secure. There were many instances that we were able to escalate concerns almost real time, whether it be to the mayor's office or to the governor's office. We wrote regular letters to the governor and mayor, highlighting the needs of our community, whether it was ventilators or BiPAPs or just PPE. There was N95 masks for our nursing homes, and so on and so forth. And really, making sure that we kept a 30,000 foot perspective at all times, but at the same time, also making sure we worked hand in hand with any agency that reached out or needed help. And I already referenced how we raised and distributed funds and supplies to under-resourced providers. Also, we worked with those CBOs that were specifically working with underserved, hard-to-reach parts of the island, and making sure that those individuals and those parts of the community that had those vulnerable populations were constantly being serviced and connected to care. And also working with the health department and making sure that all of the neighborhoods, I know they specifically were focused on underserved, vulnerable populations, and making sure that they all, as the initial testing became available, as well as later on when vaccines became available, just making sure that it was equitable and all those hard to reach portions of the community were being, aware and getting to the resources. Next slide. So, I'm going to highlight some partnerships initially for testing, and then I'll hand it over to Tina to talk about sort of a later phase, as well as some collaborations between providers and healthcare agencies. So we, in terms of testing, we're able to access and availability for highly vulnerable, underserved, and or disconnected populations. I recall early on, it was really, really hard to get tests, and the nursing home were one sector that were really struggling. Dr. Seminara, who was the nursing home representative on our incident command team, also one of the medical directors for one of the largest nursing homes. We knocked on every door. We knocked on every door to try to get tests for the nursing homes, because oftentimes we didn't know whether they had COVID or not, and they were sort of branded as undiagnosed. And looking at that nursing home population, other vulnerable group home, those with disabilities, those that were underserved, and we really wanted to make sure that those were the sectors that were initially testing available when it did become available. So also improving awareness in our local community of the testing sites. So not only did we increase awareness of the city and state sites that were stood up and the facilities, but also making sure that we had local pharmacies and other partners that were able to offer testing, that we stood up other, beyond what the city and state was offering, we stood up other efforts. We partnered with labs. We accepted donations for test strips from outside of our island, and we made sure that we made sure the vulnerable populations were first had access to those tests. And then we also collaborated beyond that between healthcare and providers, especially to ensure facility compliance. And we had done antibody testing initially, where, and Tina will talk some more about that, where the hospital then was able to process. We took the tests from an outside lab, and then we were able to process them in our healthcare facility and make sure, for example, we offered testing to our nursing home partners early on before testing was available. So that was a lot. I'm going to hand it over to Tina just to sort of put a finishing bow on this piece, and then talk about some efforts around vaccinations. Tina, over to you.
Thank you, Dr. Ginny. Thanks, Michelle. Okay, so as we said before, because of the duration of COVID, we really saw where response and recovery actually intertwined with each other. And with the early recovery piece, we did quite a few regarding the rollout of vaccines and supporting all the different phases of that rollout, understanding that the CDC and the state came out with recommendations as to what the requirements are regarding age limits, and also regarding providers being first, and the most vulnerable, the individuals with highest comorbidities being put at the top of the list. All of that was being evaluated. And as a group, we actually had to look at that. So we did pretty much look at inclusivity and equity, addressing the critical needs through the targeting of the vaccination campaigns, looking at pop-ups, looking at the older adults, individuals with disabilities, homebound residents was definitely something that we really paid very close attention to. And we also looked at updating our needs assessment to be able to address the other needs that were being created as the emergency was taking its toll. Next slide. So one of the things that we rarely tend to look at is the support of the providers. Many times in a response, we think about how we're going to help the community, how we're going to help the patients, and we're less looking at the providers and the support that we have to provide to those providers. With that being said, there were mandates that came out during the height of COVID, looking at testing. And although these mandates were coming out, there were no set guidance or guidelines as to how these different entities were going to be able to provide testing to continue to actually be frontline to their patients or to their residents. So we did have to coordinate quite a bit of testing for those providers, and even lend itself into providing vaccination for these providers to let them feel a lot safer being able to be front facing with their residents and with their patients. Also, what we did was assist in providing returning to home service provision. For example, in hospitals, obviously, once the patient is discharged from the hospital, they now have to go into their home setting where they're still having some amounts of symptoms, but they're stable enough where they can actually care for themselves. Which now home care is now it's being lent over to home care for them to provide that additional service in the home setting. So we were able to leverage a lot of those resources that were needed and that support, whether it's education, whether it's training, even in some cases providing resources to enable that. For example, PPE. Dr. Mantello spoke about some of the opportunities we had in terms of Vermont did give us a whole barrage of stacks of KN95 masks, which we're able to give to all of our coalition members, and even people who are not our members who showed interest through the need assessment forms. We were able to share that, and that's also thanks to the Greater New York Hospital, because they were the one who literally provided that that collaboration with Vermont for us to actually be able to get those masks. Next slide. So with ongoing situational awareness and assessment, which we said before, the need assessments that we were completing, we were constantly updating this information because we're going through supplies very quickly. We look at even just regular disinfectant and cleaning products. There are a lot of offices, a lot of buildings that weren't able to reopen until they were able to get these supplies. And through these need assessments, we were able to look at what we have gotten from a volunteer donation perspective to now be able to use those resources and put in the environment that was necessary. One of the areas that were critically affected also were the for-profit agencies, because with the for-profit agencies, which some of them were skilled nursing facilities, they were not getting support through New York City Emergency Management and through the city. So they had to really be standing on alone. However, as a part of our coalition, as a part of our community, we did not segregate that piece. It was important for us to make sure that whatever resources we were getting, we were able to share with the community and not just look at just one sector or one division. So that was definitely important for us to be able to share those resources across the board. Broad communication of key messaging and guidance, that was very critical for us. For a lot of the nursing homes, the home healthcare agencies, even Meals on Wheels, their education pertaining to even simple PPE, a lot of people thought just getting an N95 would be sufficient. they didn't really understand what the program involved, what the OSHA respiratory requirements were in terms of wearing a true N95. And many thought that an N95 was the same as KN95. So we had to do those training sessions to provide that training to tell them that yes, KN95 will actually provide you with some protection, but in terms of being more protected, especially for the healthcare workers, it would be the N95. And specifically for the skilled nursing facilities who really faced COVID even more challenging than the hospital themselves, especially looking at the number of deaths that they incurred within their facility, they at first were not being privy to N95 masks. They only had surgical masks and KN95. So we did a lot of messaging, we did a lot of training around that and around vaccination and testing. At one point, we had to figure out who needed to be tested, when do you need to get tested, what the duration of it is supposed to be as CDC guidance changed. And as we got more information from the state and from the city, we were able to compile that information in a simplistic form where we're able to share with everyone, the VNA, the VNS, all the organizations that were a part of the coalition, and even the ones that were not originally a part of the coalition. We were also able to identify supports for discharged patients, homebound residents. One of the things that I really wanted to point out is the real significance of Meal on Wheels. Yes, the disease was affecting us, but we also recognize that homebound residents literally still needed to eat. And for the Meals and Wheels people who are they're very active on Staten Island, for them to be able to actually go into those homes to provide that service, they needed to understand and they needed to be given education to support that effort of them feeling confident and comfortable in entering those areas. So again, this is where we did extensive situational awareness, including education, training, to be able to support that group. Ongoing advocacy and resource solicitation, the support of Staten Island inclusion in vaccination plans initiatives. One of the things that we really paid a lot of attention to were the information that was being submitted through the New York State Department of Health website. We all joke about the health commerce. We hate the system. We hate having to do these surveys and things like that. But some of the documentations that we had to put in was very helpful in terms of us being able to look at long-term recovery and long-term response. For example, when we were able to look at the age that was being impacted, we were able to look at the area codes that were being impacted. We were able to analyze the data that was in that system to now look to advocate for vaccination and pop-ups and things like that in the community that were underserved. So that was definitely information that was truly helpful for us to be able to understand within our own community where we needed to focus a lot of our attention to, because we don't know it all. It's a small group of us. Our incident command structure was less than 10 people, was literally 6 people. And our steering committee was also a small number of individuals. And as much as we have a lot of grassroots and a lot of different expertise within that area, we still had to depend on other data sources to be able to channel where we needed to put some of our attention to. We supported providers access to resources needed to safely sustain services. One of the things that we actually did do with respect to the providers was the hospitals did participate in assisting some of the providers with having testing being done within their respective sites. Obviously, a lot of these skilled nursing facilities and other agencies didn't have a lab available for them to actually conduct testing. So they had to now partner with others to be able to do that. And that's where the partnering through hospitals and the partnering through the pharmacists and all these other agencies were actually helpful in able to meet those needs that were now requirements being set through the New York State Department of Health. We strengthen service provision to homebound residents by building trust and relationship with off-borough providers. In addition, what we actually did, we also strategically did a lot of marketing in terms of being able to identify different groups that may not be readily able to get access to a lot of things, including vaccination, where we literally had pod clinics that was set up in hospitals to accommodate for that, for not just for the providers, but for the actual homebound residents, where they will literally even bus them to the site to actually have that done. And there were some efforts that were made off island in terms of bringing the vaccine to the individuals' homes. That was also a part of the efforts that we were able to implement on Staten Island. And even though Staten Island have always been known as a forgotten borough, I must say that during COVID, with all the efforts of all the individuals, even right now in this session, we were able to actually bring a lot of resources to this island. And I'm truly proud of the work that all of you guys have actually done in being able to bring that to light. I think we stand out. We stand out among all the other boroughs because of how unique our identity is with respect to the collaboration and the cooperation that we've actually extended ourselves to. Partnership for vaccination, as I said before, the pop-ups that we had serving key populations such as the older adults. We had pop-ups. We also had various different locations that we had those set up, and you can see pictures of on the side that shows us some of the pop-ups that we actually had. Individuals with disabilities, that was actually something that we also paid close attention to. And we did make sure that these populations, these vulnerable populations, were not forgotten at any given junction, especially when we're talking about vaccination and those resources that were needed for them to survive the disaster. Group home residents, that was also a piece. Sorry, Michelle. Group home residents, as I said before, we actually were able to go into some of them. Some of them were able to actually come to the site to be able to do it. And overall community awareness and campaigns with the CBOs and the support to raise vaccine confidence and equity. Extensive work was being done surrounding that in terms of trying to encourage individuals, even in situations where we found that a minority group was actually not taking was not really interested in actually taking the vaccine. We started having different sessions. Dr. Mantello was also the charge with those sessions, being able to have that education and sharing the education as to who is most vulnerable and try to encourage people, bringing even people from a various different background and culture to actually speak of their own personal experience to gain more interest and attraction to taking the COVID vaccine. Okay, and now I'll turn it over to Dr. Mantello to go through the framework for the collaboration. Thank you all.
Thank you. Dr. Mantello, did you want to tack on a little bit here as we kind of transition from examples to frameworks?
Absolutely. Thank you. Thanks for that, Tina. Yes, I think we do. I do agree that, you know, there's definitely something very special about our community, and you will see that there's a tremendous amount of commitment, and you'll see the same dedicated public health partners over and over again. And we often talk daily, hard to imagine, but you know, we're in constant communication, making sure we're addressing the needs of our community. I want to really give a shout out to our local pharmacies. Some of our pharmacists, I mean, and I say this not in jest, I could call them and the answer would be yes, even before they heard the question. And then it would be like, okay, we'll figure it out. So whether it was individuals with disability, also I want to emphasize, because we're a small community, we didn't necessarily get multiple drive-through sites to the state or multiple mass vaccination sites to the city. So oftentimes many parts of our community couldn't get to the state site, for example, was a drive-up site. So we did partner with local pharmacists to actually look at areas of the community that, it perhaps took people 2 buses or whatever to get to a drive-up site. And if you didn't have a car, you had to walk up to those drive-up sites. So there was a lot of barriers, and our pharmacies and pharmacists really, really stepped up. And I'm talking about the community pharmacists, not even the big chain pharmacies. So these pictures, the bottom pictures from Wagner College. So we set up a site at the campus, not only to vaccinate the students, but we also had those with disabilities come, with their loved ones, perhaps drive up, and the pharmacists would go outside. And we did this at the pharmacies also. The pharmacists would go outside physically and vaccinate those individuals which couldn't get to the site. And then just a little bit about the homebound effort. And the reason why it's critical is because this is where our home care and hospice agencies were critical. This is well before the city set up a effort to send EMS to the homebound individuals. So we had started to think about, who are those homebound residents? I mentioned Dr. Seminara. She oversees at Northwell a senior program, and they have about 350 homebound and seniors that her and she and her nurses oversee. So starting with that program, as well as bringing in our hospital hospice, bringing in our visiting nurse association, VNA, VNS, also thinking about, Tina mentioned Meals on Wheels, bringing in the Department for Aging, bringing together CASC, which is Community Agency for Senior Citizens, and also at the same time collaborating with the mayor's office as well as the city health department. We put together multiple calls, starting to put together lists of where these seniors as well as homebound individuals with disabilities might be, and how we were going to get to them. We began to actually send oftentimes nurses and pharmacists to their homes if we were able to contact them. We started to cold call people through the Medical Society as well as through Dr. Seminara's program, just to check if they had someone to pick up supplies for them, if they had a way to get to a vaccination site, if they had any other needs that were not being addressed. And so a lot of those efforts resulted in us being able to reach many of our homebound residents. Also, we knew that individuals were getting discharged from the hospitals, and if they were not being sent to nursing homes or long-term care facilities, and they were getting sent back home, many of the visiting nurse agencies were not yet sending their staff out in person. So we had to make sure that somebody stayed in touch with those individuals, and that transition to care was seamless, because we know sometimes they decompensated very quickly when they were sent home and they didn't have the support structures or the ability to get back to care. So I want to just give a shout out again and speak to the importance of having knowing the lay of the land and making sure that you're connected, especially in downtime, with all of the agencies that are doing this work. I wish that we had had a better sense, prior of knowing just what the ecosystem looked like. If we had been in touch regularly, and we, for example, connected with the dialysis umbrella agencies, and now connecting with the umbrella agencies. We connected with the umbrella agencies for the nursing homes. We connected with the umbrella agencies, but it all happened well after we were into the thick of the pandemic. So I think just emphasizing that, staying in constant communication within the agencies in your borough as well as the umbrella agencies. It's key because if, and I say, I shouldn't even say if, we all know it's not an if, it's a when, that when the need arises and there is such a mass disaster again, and no one obviously expected this to be at a global level, but we would be really kidding ourselves if we think this is not going to happen again. And I know this is like, we say it's a once in a lifetime, but no longer. I mean, I think the world is shrinking, travel is so much easier. I think that we really have to be thinking very seriously about being prepared for the next one. So next slide.
Perfect segue, Dr. Ginny. Thank you so much. Thank you so much. And I think what I hope that you've heard a lot of here is what collaborative response really can look like, right? I think the benefits of the collaborative response are here. We heard Tina and Dr. Ginny both speak very clearly and consistently in the we, not the I, right? And that is the strength of coalition. And so I think that the case example, we really meant to walk you through that initial COVID response and then the early recovery period, and the ways that our COAD coalition and the MES within that, the medical ecosystem embedded within that, we're able to run a fairly effective collaborative response is a bit of a framework. We want to now really, hopefully, bring it full circle for you all and say what that preparedness piece can look like, right? What is actionable? And thanks to the few folks in the chat who have shared questions to that effect, right? This is the line of thinking we were hoping to spark for you. Which is, well, how do I get involved? Do I join a COAD? The first and foremost thing I wanted to share here, and I lifted this quote straight from the after action report of our COAD, which was a high level takeaway of the whole group, was very simple. Do not let the perfect be the enemy of good. And so that, I want to lead the collaborative preparedness piece here by saying, it's good to just get started. It's good to be thinking about collaboration. It's good to be in this shared space and learning and jotting one idea that could resonate with you. It doesn't mean we're all prepared today. It doesn't mean you're joining the COAD tomorrow. And I think Tina and Dr. Ginny will be the first to tell you, nothing about our case example was quite perfect, right? I think, of course, we're here in this space trying to turnkey the activities, the lessons learned, because we want this to be a model for others, but it's not to say it went smoothly every day or most days, perhaps, and it's certainly not to say that it was a perfect iteration of collaborative response. Crisis rarely can be, right? But what it should lend us is some food for thought and some ways to start getting going. So I want to lead here with acknowledging barriers and identifying opportunities. And for transparency, this slide was initially called Managing Expectations. So allow us to do that, right? That nothing is perfect. Successful coalition building and this collective preparedness effort is a long-term effort. We heard Dr. Ginny share that the MES initially came together in 2015 and then was activated in this way 5 years later. And was it perfect? It was not. Were folks still scrambling? Yes, they were. But the long-term nature of this effort is inherent. And if we can kind of acknowledge that as a challenge up front, really buckling down and then dedicating yourself to that effort is what yields success. This work does take a commitment. It's a commitment of time, a commitment of resources that allows for the human capacity and the human capital to really sustain collaboration in all of those phases, right? We heard that this is a group that was really heavily focused initially on preparedness and mitigation work, and even just sustaining that is, of course, a challenge and does require human capital capacity, trust, existing relationships, some funding, some connectivity to the government, right? It can be, in my experience, almost particularly challenging to keep folks engaged during these blue skies, if you will. And so collective preparedness is a hard sell for folks, because if it's not top of mind, it might not fit into your calendar, but committing that time and resources and identifying partners and maybe existing anchor organizations or coalitions, which I'll speak about in a moment, can go a long way in ensuring that your organization or agency can kind of at least get started, right? Looking for an opportunity to say, hey, I can send a staff member to that meeting once a month. And that's a way for you to really begin seizing on the opportunities and overcoming or at least identifying the barriers within your own agency to participation. It's notable, of course, there's logistical and cultural and regulatory factors that often present both barriers and opportunities, right? Community-based organizations face and function differently, challenges and opportunities, than do clinical and health and medical service providers, than do our education institutions, and et cetera. But as we've been hopefully trying to convey, the strength is in numbers, and the diversity of perspectives and expertise that come together there is how those types of challenges can be overcome and turnkeyed into real community assets. And one point that should go, I'm sure not unnoticed by folks in the room, but really it's worth naming it. The support of government and local officials was critical to the success of Staten Island's COVID response efforts, and it is critical to collective preparedness, right? So really building and sustaining coalition that is focused on preparing and building resilience within a community. We, of course, have the privilege and pleasure of Dr. Ginny being engaged, and as she mentioned, really having a foot in both spaces of the public sphere and the health and clinical space. It doesn't have to be you that is the person connected to government and local officials, but again, identifying those avenues where you do have connectivity and looking for anchor groups or existing coalitions that can position your agency to be better connected and rally that support from the government and local sources is really critical. And I do think that we see New York City government, at least, very amenable to this model, which is a great thing. So our suggestion here in terms of framework and what can you do or maybe should you do if you're feeling, like, okay, well, Staten Island did all that, so what should I do? Getting started, as I just noted, doesn't mean you have to lead the charge. We're not here to suggest anyone try and stand up their own entire preparedness coalition. But a great place to start is positioning your own agency to contribute to collective preparedness. And so what does that look like? Little bit of an in-house inventory, right? Little self-reflection as an agency. What tools, what templates, what communications plans are already in place? Are they updated? When was the last time you were updated? Did you tell the funder they were updated, or did you really do it? And do those plans consider things like staff care? We saw, of course, no, not that it needs stating, especially to this audience, but tremendous burnout and mental health challenges and vicarious trauma experienced by those serving in response to COVID-19. Do your plans have that embedded somewhere? What care is being afforded to staff? How are our contingency plans considerate of staff needs in that way? And those are things you can start doing in discussions with internal leadership to get prepared to collaborate. Also thinking about stakeholders you're already connected to. As I mentioned, government agencies, but you're probably also having linkages with social service providers, other medical care providers or social care providers. What do those partnerships look like? Just mapping that out. And they don't need to be overly extensive, but if you know that there is a partner and they are in our neighborhood and we work with them on X or Y, that's a great place to just start, as we have collaboration and we can prepare better together. And then engaging staff. This is one other kind of like internal suggestion, perhaps. Refresher training. I know that in some cases this is, mandatory, regulated, but if and as you're updating tools, templates, comms plans, offer the team protocol refreshers, continuity of operations refreshers, or things to highlight what it is that you as an agency hope or plan to do differently or more collaboratively in the future, and really engaging the team in knowing that emergency preparedness in-house can position your agency to better participate externally in the broader community. And then, of course, what we want to really advocate for at the end of the day is get involved, get engaged, evaluate the potential role of community stakeholders in your agency planning. And that might mean building inclusive partnerships, thinking about what do CBOs operating in your neighborhood, or CBOs who are currently serving your patients or your patients' families in these ways, what do those shared goals suggest about ways and opportunities that you can connect? It doesn't have to start off as, let's make an emergency plan together, right? But it is about, what do our shared goals and missions tell us about ways we can connect with one another in blue skies on a day-to-day basis, and what then might those folks have to contribute to the ways that you do your agency planning. This might mean sending a staff member to a community event or a coalition meeting, and again, doesn't have to be overly burdensome or taxing on folks' schedules at first, but showing face can go a long way. Shaking hands and handing out a business card, great way to start. Great way to get an invitation to a different space or connect with a new leader who you didn't know could help your agency in such and such a way. Pursuing those partnerships also maybe with a strategic approach that could address capacity gaps. I know for a number of our entities here locally, for example, language access, big challenge. So thinking about CBOs who have teams or again are serving constituencies with particular native languages or who have cultural credibility on their team that your agency would ultimately benefit from in a response effort. These are all great ways to just start identifying folks in the community with whom you can build greater partnerships and longer term collaborative preparedness with. And then, of course, I want to end with the point of yes, meet your local COAD. Department of Health, I'd be super remiss if I didn't make this point. The Department of Health does fund a community emergency network in each borough, whether they call themselves a COAD or otherwise, most do, but their structure is the same. And for clarity, they do not all have a medical ecosystem subcommittee. Some of them, I think, have medical and health sector partners engaged in their coalition work. There's also healthcare coalitions, specific borough-based coalitions that are funded through Department of Health as well. And then, of course, other umbrella agencies like associations that have convened us here today. Get connected, reach out. I know a link was shared in the chat for some guidance on navigating those spaces, and I'm also happy to share. I know, for example, we have a South Brooklyn COAD, a Lower East Side COAD, as well as an East Harlem COAD in Manhattan. We've got one or two out in the Rockaways in Queens. And who am I missing? We have Staten Island. I'm missing a borough, but I promise. Oh, Bronx. Oh my goodness. Yes, and we have there's a coalition serving up in the Bronx as well, and I think East Harlem might do some overlapping work there. So again, the network may not be embedded or housed in your neighborhood particularly, but many of these networks have a mission to serve a region within that borough, and that connectivity can be really critical. Again, don't overcommit. We're not suggesting you go and get into the planning, but say hello. Do an outreach, visit a preparedness event, and see where that can take you. Oh, and my co-facilitator has one more note. Tina, please allow me to let you end, and I'm going to throw our contact info up on the screen while you do so.
Sure. Thanks, Michelle. Just to let you guys be aware of it, yes, there are coalitions that exist across the various different boroughs, but I will tell you that Staten Island Coalition is the most unique because the majority of the others, if not all the others, are healthcare specific. So it is important if you're going to link with a coalition to find out exactly what the coalition is about, what their dynamics are. In some boroughs, you will have more than one coalition, but the coalition may have a specific focus. For example, one may be focusing on the dialysis center, one may be focusing on pediatrics, and the other one may be focusing on healthcare. So you just have to you just will have to, during your survey and your evaluation, be able to ask questions to determine what the coalition is, how they're actually in existence, and how they collaborate. There are also coalitions that may not do response and recovery. Majority of the coalitions that exist are mostly on focusing on situational awareness. So they only focus on mitigation efforts and planning. So again, just understanding what coalition exists and how you would be able to address whether or not it will actually meet your needs. And that's not just in New York, it's also in Chicago. The coalition exists across every single state you can possibly think of. It is something that have been in existence for years. They have symposium that are launched in various different states that bring all these different coalitions from different states together, that speaks to the work that the coalitions are actually actively being involved in. So again, just know what coalition you're interested in by doing your research and by connecting to see whether or not it is the suitable coalition for you to participate in. And I'm sorry, lastly, one of the challenges, the major challenges, and it's not just with our coalitions, with everything we do, the major challenge has to do with keeping in connection with individuals. Unfortunately, even though you may have a list of contacts for every single person within your coalition or within your group, those people change rapidly. And we saw that during COVID. At the end of COVID, the administrators all switched in majority of the skilled nursing facilities. Like whoever was at Verrazano went to Edgar. It was literally like jumping ship, changing roles, changing organizations. But what is important is actually identifying the name of the organization. If you have the name of the organization, then you can quickly be able to identify who in that organization would be playing that role of emergency preparedness and be able to link you to what you need to do within that organization. And that's it. Thank you.
Thank you. Anything else to add, Michelle? I didn't mean to take your screen down prematurely.
No, not at all. Thank you so much. If anyone is interested in reaching out to us, we're always happy to chat. No, thank you all so much. We hope that was helpful and sparked a few ideas across the audience.
I was trying to make sure we got Mr. Rogers back up. Can you see Mr. Rogers? Okay. That's great. Thank you.
He moved to Staten Island.
What'd you say?
I think he moved to Staten Island.
What a great presentation. And you know, I have to give another shout out to Fidel Monroe, who's here from New York City DOHMH. You mentioned government partners being critical, and they are certainly critical to our efforts in home care and hospice. So again, thank you to them. And as a pharmacist for many decades, a shout out to the pharmacists that really helped you out. And last but not least, I do want to say I was not in this space during the height of the pandemic, but I have heard a lot of stories about home care coming together to get PPE to the agencies, and I'm told that that was actually kind of a jumping off point for home and community-based services to get involved in emergency management because we really showed what we can do. So just wanted to mention that. We are going to just go really quickly because we want some time for a conversation to just talk about some current issues in emergency management. Respiratory illness season is here. Let's not forget about other communicable diseases like measles. Measles are on the rise, and most of that is due to lack of immunization. So please, 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 please urge your staff and your patients to get immunized, get up to date on all their past immunizations. Whooping cough is making a comeback. That immunization is now recommended for every pregnancy and for folks that are going to be around a newborn. So keep that in mind. Besides COVID and flu and RSV, which all can be given at the same time, and under the Affordable Care Act, most of these vaccines are available free of charge. For the uninsured, don't forget that federally qualified health centers and local health departments offer uninsured and underinsured folks free vaccines. COVID tests are available again by mail. I believe that link is on our last slide. Even if you just Google free COVID tests available through the Postal Service, I'm told at least through the end of the year. So make sure that your patients and staff have tests on hand so they can protect other folks from getting sick. One real quick update on the shortage of IV fluids that was due to the Baxter plant problems after Hurricane Helene, during and after the hurricane. Baxter is providing regular updates on its dedicated website. The link is on the last slide of this presentation. At last report, which was November 26th, I believe, allocations were increased, and there's about a 1 to 2 week lag time for products to flow through the distribution network. Barring any unanticipated developments, Baxter is stating that it expects to have planned phased increases again in mid-December and at the end of the year, and some IV products will be at 100% availability by the end of the year. So that is the update on Baxter, and now I'm going to turn it over to Eva, who is going to, or Eva, yep, Eva's going to talk about wildfires and the drought conditions that some of you have experienced.
So you might wonder where Carol, Ariana, and I get all this great information that we email out to you. And on the last slide are all of the useful links that we're referring to. So I'm really not going to talk too much about wildfires and drought conditions because you all know we've had unprecedented weather emergencies over the last few years. There's a link on the final slide to the New York City Advanced Warning System, and that is where we found the information for wildfires and drought conditions. It's also where we found information for heating, for HEAP. And I did not know until I read that includes like furnace and boiler inspection and repair. So I find these little tidbits of information, but I encourage you to read or visit the New York City Advanced Warning System for heating assistance, for air quality, any weather emergencies that you might encounter. You can look at that. It's great reading. Ariana?
Yes, thank you. So a few reminders on my end, the Comprehensive Emergency Management Plan training, HCA, along with our collaborative EP partners at HPCANYS and HCP, developed a SEMP training for home care and hospice providers under the New York State Emergency Preparedness Grant. The purpose of the SEMP training is to provide personnel at home care and hospice agencies across the state with information and tools to develop a SEMP to prepare for, respond to, and recover from natural and man-made disasters. As a reminder, the SEMP tool is an optional tool, not a requirement of DOH, but is offered to assist agencies to enhance and strengthen their existing emergency preparedness and management plans. Agencies may also use the SEMP document and tools as their main planning documents. The SEMP training is available through an interactive online module that can be found on the department's learning management system free of charge. And again, that direct link to enroll into the training is provided in the last slide of today's presentation. Moving on to the health commerce system, the HCS is used by the New York State Department of Health to communicate important and time-sensitive information to healthcare providers. Regulations require home care providers to keep HCS information up to date to optimize communications in emergencies and enable agencies to perform mandated functions. I just wanted to provide folks with a quick reminder that home care and hospice agencies are required to establish and maintain current HCS accounts, keep agency contact information on the HCS communications directory current and updated. This includes reflecting any changes in general information or staff roles as they may occur. This information should be reviewed on a monthly basis. Agencies should access the HCS at least once every 24 hours and more frequently during an emergency to get news, announcements, alerts, and other important department communications. And lastly, agencies must have an appropriate and applicable policy and procedure regarding the HCS in place and reviewed at least annually. And then quickly, I just wanted to share another good free resource with you all. The New York State Department of Health Office of Health Emergency Preparedness releases a monthly newsletter called Aware Prepare Update. This newsletter highlights EP-related press releases and current events, and it also provides upcoming trainings related to preparedness, readiness, and response. These trainings are provided live or in person. Some might be on demand on that on the department's learning management system. So you can sign up for the newsletter by clicking on that link in the last slide of today's presentation. And I think we're gonna now open it up to you guys. So feel free to put any of your questions in the chat. I think we can also have folks raise their hand and come off of mute and ask any questions as well.
I think so. Any topics that we didn't cover that you have questions about? I didn't mention that the flu has not been declared prevalent yet in New York State, but it's still important to have your folks get immunized or wear a mask per regulations so that it doesn't sneak up on you once flu is declared. And Eva made a comment about the work moves at the speed of trust. I wrote it down too.
It's so true, though.
It really is. Usually everybody's a chatterbox at the end of this. We wanted to make sure we had enough time. Nobody has any questions or comments. Everything is hunky-dory, perfect. And a reminder, you will get, oh, I'm sorry.
I do have a question. My name is Cheryl. I just wanted to know how, I think coalitions are important. I am involved in a couple of coalitions, but not in regards to disaster preparedness. How do I find coalition in my work area that I could join up with to make sure I stay current on what's going on in our community? We service the New York metropolitan area, my home care agency, and so how do I join up with a coalition, or how do I find out where there are coalitions doing similar things to what you guys are doing so that we can stay current?
I'm going to have Michelle answer the question as after I have a quick comment. One way to stay informed for sure is to join an association. HCA, HCP, and HPCANYS are the three home care and hospice associations, and we get information out to everybody. We also get information out to folks that are not members, opportunities like this, and any alerts that we put out are put out to all agencies, not just our members. So if your HCS information is up to date, you ought to be getting those alerts. But I'm gonna
we get that, but I wanted to join personally so that when I service my patients, I have correct information and I'm ahead of the game.
right. And you can reach out to us about association membership.
Okay.
It gets you not only emergency management information, but also regulatory, legislative information, education opportunities outside of emergency management. But as far as like a local emergency management coalition, I'm going to let Michelle take that question.
Yeah, thanks so much. And anchor associations, absolutely a great starting point. I'll say that for a number of our CBO COAD members, the folks who are, nonprofit organizations or faith-based, they generally find the COAD through their membership at Nonprofit Staten Island, right? Or their connectivity to Nonprofit Staten Island, and then understand that we kind of host and facilitate this embedded coalition. So anchor associations are a great starting point. And then I don't want to put anybody on the spot, but I do think I saw Al on the call at DOH, who I know has a role to play here, particularly in the coalition building for health services providers. And so again, Al, I don't want to put you on the spot, but I do want to say that Department of Health does some great funding of borough-based healthcare coalitions. And I think there's some links at the end of this slide deck that you can certainly click when it's circulated to kind of identify how to get engaged in those. And also you can feel free to touch base with me, and I'm happy to just better unpack a little bit of where you're serving and maybe point you to a point of contact or two. At least you mentioned the metro area, which of course is broad reaching, but even just kind of starting with one borough or one neighborhood that's active and looking for some connectivity to health services providers could be a good starting point. I think the alert systems, the anchor associations, always my recommendation for first line of defense. And then to really get to that hyper local level, I think it's about identifying where your sites and teams are operating and looking at those either healthcare preparedness coalitions and or community-based, like the COAD coalitions that are operating in overlapping geographies.
Thanks so much, Michelle. If you can hear me, I hope so.
Yes. Yep.
Wonderful. Excellent. Well, thank you all for the invitation. So my name is Al Villicar. I'm with the New York City Department of Health and Mental Hygiene. I'm incredibly lucky to work with Fidel and our great team here. But I was excited to join this conversation today. And yes, I did want to chime in. I was waiting for everyone else to chime in, but I wanted to chime in as well to say that this was fantastic. I think in Fidel's opening remarks, she alluded and touched several times regarding the New York City Healthcare Coalition and who's a part of it. We're all a part of it, right? And we're working to continually ingrain all of the different sectors of healthcare because we all play a role and we all make the collective go, for lack of a better term. And so, but no, to the point that's discussed, yes, get engaged in any way, shape, or form that you can, right? Certainly the associations that were mentioned, the COADs and any and all that you could be part of. I think it was Dr. Ginny that had mentioned, during her presentation, that it was going so fast, right? And that they were meeting colleagues and learning how to work together. And, for colleagues that have been involved with emergency management, or if you're newer to emergency management, and there's always the famous saying, and I always say it, we don't trade business cards during the disaster, right? We want to get to know our partners and know our colleagues and know how we work together and who brings what to the table so that we can have that integrated response as much as possible. But situational awareness is paramount, right? During these events and disasters, and even with noticed events and things, the more situational awareness you could have, the better. And if you get it twice, that's okay, right? But it's better than not getting it at all. So definitely get engaged. And I will say, again, the coalitions and the COADs and the associations and all the great outreach that happens, but even things like from some of our other partners, right? From NISM, NYC, Notify NYC, right? MTA alerts, getting in tune with it all, right? Because getting those updates, we all live in this area, right? And we know when those big snowstorms happen and the challenges that it faced. But if you're having that updated information about closures, right, and about delays and things like that, because again, it all comes to serving the patient ultimately. And then lastly, I'll also put a plug for January 7th, and the coalition, the New York City Healthcare Coalition, is our first meeting of the year. And I know some of Michelle and some of our colleagues from Staten Island COAD will be speaking there as well. But again, bringing all those layers of healthcare together. And so you're certainly welcome to join the conversation with us as well. So we're looking forward to it. So I know I'm talking a lot, but I'll stop there. Thank you so much again. This was wonderful.
The Healthcare Coalition meetings are always so informative. I'm really happy to get to hear from Staten Island again.
I just wanted to point out one other thing, Cheryl, and that is, as a home care or a hospice provider, no matter how big or small, you have an expertise. So don't forget that you also have something to bring to the table.
Absolutely.
Okay?
Love it.
Yes, no, I'll piggyback on that, right? No one knows your sector and your realm better than you do, right? And it's a learning process for us all, right? And again, I sound like a broken record sometimes. There was a point for healthcare emergency management where if you were in a hospital with an emergency department, you didn't play a role. That was the thought, right? When I started in New York City healthcare emergency management community, and it's not all that long ago. But Hurricane Sandy and the COVID pandemic, of course, and so many instances, it shows everyone plays a part. And so so know that you do, and know that it's a vital part. Thank you.
Thanks,
And,
Al. It kind
and
of goes back.
just
Oh, go ahead. No,
sorry. And just to add to that, like I was very impressed to hear because I've never been in a presentation from home health care and hospice, and I was very impressed to see how far ahead you guys have gotten, even with the less resources than hospitals, because we have gotten a lot of resources to be where we are at. But for you guys to have been to that extent, I'm very much must applaud you guys for all the work and effort you guys have actually made movement this far.
oh, thank you, Tim. We're the scrappy sector.
Thank you.
You're doing great. You are absolutely doing great.
Thank you. Does anyone else have anything to add? I'm going to flip us to our contact slide so that you have contact information in a moment. But first, we want to remind you to complete the evaluation for today's program. We can only get better with your help. We don't know what you need unless you tell us. So please do fill out the evaluation. You can snap the QR code. You can get the link off the screen. You can wait for the email later, but please don't wait. Better to do it now. Darren Pruitt at New York City DOHMH always says, you know, the QR code really helps to get the evaluations done faster. So please just do it before you forget. We need to hear from you. We need to know what you liked, what you didn't like, what you want more of. We don't want to waste your time. We certainly don't want to misuse resources providing information that you don't need. So do fill out the evaluation. It's extremely important. And last but not least, here is the contact information for the 3 associations. Excuse me, Ariana Stone at HCA, New York State, and I am Carol Dio at HCP, and Eva and her colleague Jean Chirico at HPCANYS, all happy to answer your questions about anything at all, emergency management, membership, how you can get involved. We can connect you with the right folks. So, and remember, you will get this slide deck afterwards, so you don't have to be too busy scrambling to write all this down. QR code is handy right up in the corner to get you to do that evaluation. That's so important. And then the last slide will just be useful links. You'll get that when you get the slide deck. Covers some of the stuff that we've talked about today, gets you to even more resources if you need them.
Carol, I would like to say thank you to the Staten Island COAD. Thank you, Al, for your joining the conversation today. I want to thank everyone for joining. And as Ms. Powell asked how to become involved, not only having your staff leadership at home care involving your paraprofessionals, your staff aides, etc. Have them, your coordinators, have them involved when we have our regular in-services, you know, working with the community, have community members, emergency preparedness personnel go in and speak with them. They share those things as they learn, and that's how we develop as we go along. Thank you so much to the associations for this wonderful presentation in collaboration with the Staten Island COAD again. And I have started to when I send out emails, I am adding the link to the New York City Healthcare Coalition. You can find many answers to your questions there. And if there's something there that you would wish more information on or you don't see there, feel free to reach out to me or any of today's presenters. Again, thank you so much.
Thank you, Fidel. We can't do any of this without your support. And I have to give a shout out to Donna McNamara, who has a room full of people to watch this program. And that's what collaboration is about. So thank you, Al. Thank you, Fidel, Ariana, Eva. Say goodbye.
Thank you, everybody. Have a great day.
Thank
Thank
you.
Thank you so much.